Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Methamphetamine Use and Methamphetamine Use Disorder. And our presenter is Dr. Ramsey, Chief of Medical Services for New York State OASAS. Dr. Ramsey will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks, Dean. First, disclosures. I do not have any relevant financial disclosures, and I will be discussing off-label use of medications for the treatment of methamphetamine use disorder. Let's go over our learning objectives. Discuss the pathophysiology of substance use disorder and vulnerabilities for developing substance use disorder. Discuss screening and diagnosis of substance use disorder, and discuss the epidemiology of methamphetamine use disorder. Discuss effects of methamphetamine use, including psychosis. Discuss psychosocial and pharmacological treatment options, including off-label use of pharmacotherapy for methamphetamine use disorder, and discuss safety tips and overdose prevention for persons who use methamphetamine. First, the pathophysiology of substance use disorder. On the left-hand side is the ASAM, or American Society of Addiction Medicine, definition of addiction, which they updated in 2019. I'm going to read this short definition and then talk a little bit about the brain pathophysiology of substance use disorder. Addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are usually as successful as those for other chronic diseases. So it is a very complex process to understand the pathophysiology of substance use disorder. This graphic simplifies it into three phases involving three main regions of the brain. The first phase is binge intoxication, and that is focused primarily in the basal ganglia. The next phase is withdrawal and negative affect, and that's primarily focused in the extended amygdala. And lastly, there's preoccupation and anticipation, which is grounded in the prefrontal cortex. The interplay between these regions of the brain and these three phases leads to the cycle of addiction. In the binge intoxication phase, high doses of dopamine or high levels of dopamine are released when someone uses substances, and this is highly reinforcing. When someone is experiencing withdrawal from using a substance, that is associated with a negative affect or dysphoria, meaning that individuals feel more depressed and do not obtain pleasure from standard things that they received pleasure from previously. That draws someone into the preoccupation and anticipation phase, which again is grounded in the prefrontal cortex. The prefrontal cortex doesn't fully develop until we're approximately 25 years old. And given that substance use starts most typically for people in the teens or early adolescence, individuals do not have a well-formed prefrontal cortex yet, and the prefrontal cortex is what helps us weigh consequences of our actions and to do long-range planning. So coupled with substance use, it makes it more challenging for individuals to see the consequences of their actions and be able to not engage in such actions. We're going to talk about the vulnerabilities for developing substance use disorder. Much of the risk for developing substance use disorder is a genetic predisposition, which accounts for anywhere between 40 and 60% of the risk, depending on the substance. Also, particular mental health diagnoses, when they exist as comorbid conditions, cause somebody to be more vulnerable to developing substance use disorder. These mental health diagnoses include bipolar disorder, anxiety in any form, major depression, ADHD, specific personality disorders such as borderline personality disorder and antisocial personality disorder, and antisocial conduct disorder. Many individuals with substance use disorder have a history of trauma and or abuse. For females, that's particularly pre-adolescent sexual trauma, and both males and females have been victims of or witness to violence. Consider doing the ACE score with any patients coming into your care, regardless of what their diagnosis is. Often individuals may have poor coping mechanisms, and using substances is a means of escape. Impulsivity plays a role in the initiation of substance use, particularly when individuals do not have a well-developed yet prefrontal cortex, but also some of the mental health diagnoses listed above are associated with impulsivity. Sensation or novelty seeking may play a role in the initiation of substance use. Environmental triggers or sensory cues are often triggers or drive someone to use or resume use. They may associate a particular smell or a sound or a location or an individual with using substances. And as I started to explain on the last slide, a lack of homeostatic reward regulation, so reward deficiency. When we use substances, we become oriented both from an anatomical and a physiological perspective in the brain towards those pleasurable rewards. So we prime the brain with early substance use. This is looking at adverse childhood experiences that I mentioned briefly on the previous slide. What comprises adverse childhood experiences? It's a variety of types of trauma. So there are a variety of types of abuse, physical, emotional, and sexual abuse. Two types of neglect, either physical or emotional neglect, and then several different markers of household dysfunction. So that could be a diagnosis of mental health issues in a parent, an incarcerated parent, substance use in a parent, violence in the home, particularly a mother treated violently, and then divorce or separation of parents. And the impact of ACEs is not benign. It affects our health outcomes in many ways. So, first of all, you have generational and or historical trauma that may exist in that family, that community, that neighborhood. Then there are social conditions which provide a local context. Then you layer upon that adverse childhood experiences, which actually cause disrupted neurodevelopment. This leads to social, emotional, and cognitive impairment, an adoption of a health risk behavior to cope with that trauma. And that leads to potentially disease, disability, and additional social problems. And it can even lead to early death. I want to talk briefly about stigma. We do see stigma in many healthcare settings. So, what is stigma? Stigma includes attitudes, beliefs, behaviors, and structures at multiple levels, including the individual level, the group level, the organizational level, and the system level. And stigma can lead to prejudice or discrimination against people with mental health diagnoses and substance use disorders, to name two particular diagnoses, but against individuals with other health conditions as well, such as HIV or hepatitis C. Stigma perpetuates stereotypes and assigns labels to people like dangerous, non-compliant, incapable of managing treatment, dirty, in quotes, at fault, etc. It can also be internalized to make people feel that they are not deserving of being treated with dignity and respect. This leads to further fear, shame, and isolation, and feeling unwelcome, judged, or unworthy of seeking or receiving services. Stigma also limits a person's ability or desire to access services, and ultimately, stigma contributes to suboptimal and sometimes traumatic healthcare experiences and health outcomes. There's also a relationship between stigma and trauma. We should recognize that most people have experienced trauma. And as I mentioned, that could be personal trauma or it could be generational or historical trauma. People with a substance use disorder are more likely to have experienced trauma, including healthcare trauma and pharmacy related trauma. So, in those particular settings, we should recognize how that trauma affects people. As I mentioned, it impacts physical health, neurobiology, and cognitive, social, and emotional functioning. And again, things that we perceive as high risk behaviors can be a way of coping with trauma. So we should recognize that that may have a benefit that's identified by the person that's engaging in those behaviors. Consider how past histories of trauma, violence, and layers of disadvantage and stigma, and for example, racism, may affect the way that an individual engages with providers in the system. And we should all be committed to not repeating trauma or basically creating more trauma by re traumatizing individuals. It's very important that we not use stigmatizing language, either verbally or in our written documentation, such as our electronic medical records. So here's just one example. There are many examples online of sort of dictionaries of non-stigmatizing language. On the left-hand side comes from the National Harm Reduction Coalition, showing some of the words that we should be avoiding. So we should not be using terms like addict, abuser, junkie, etc. Rather, we should be using person first language, as that means that a person is first defined as a human and then they have a particular condition. That condition does not define them. So, for example, person with a methamphetamine use disorder. We should not be using the terms dirty or clean to define toxicology results, people's time using or not using. Because again, when we say that somebody is clean, that implies that they were previously dirty. And we do not use such stigmatizing terms with individuals with other medical conditions. On the right-hand side is showing the difference between deficit-based language and strength-based language, and we want to focus on strength-based language. So, for example, the word manipulative is a deficit-based word, and what that's saying is that you feel like that person's trying to get something over on you, and they're trying to manipulate you or manipulate the system, etc. A strength-based way of reframing that same situation is essentially that person that we're calling manipulative is trying to advocate for themselves for something that we don't think that they should have. So another way of saying that is that that person is resourceful, and that would be a much more powerful way of describing somebody in a strength-based framework rather than a deficit-based framework. So, how do we make the diagnosis of substance use disorder? We use the DSM-5 criteria. So, at least two criteria must be met within a 12-month period in order to meet the diagnosis of a particular substance use disorder. So, the different aspects of the DSM-5 include physiology, so both the concepts of tolerance, using more of a substance to get the same effect or getting less effect with the same amount of a substance, and withdrawal. So, a characteristic withdrawal syndrome or a similar substance taken to avoid withdrawal symptoms. The core problem of substance use disorder is a knowledge of adverse consequences, but continued use. So again, it's a compulsion to use over which that individual does not have control. There's internal preoccupation, which consists of several aspects: a desire to cut down on use or unsuccessful attempts to stop using, a lot of time spent acquiring, using, and recovering from use, larger quantities used over a longer period of time than intended, And what was added to the DSM-5 from the DSM-4 was craving or a strong desire to use. So that had never been recognized before the DSM-5, and we know that that is a strong trigger to use or to resume use if you don't control for the cravings. That is particularly true with opioid use disorder. There are external consequences, so activities are reduced or given up because of use. Role obligations are neglected. There are social or interpersonal problems and recurrent use in situations that are physically hazardous. To meet a diagnosis of mild substance use disorder, you would need to meet 2 to 3 of the above criteria. For a diagnosis of moderate substance use disorder, you would need to meet 4 to 5 of the criteria above. And to meet a diagnosis of severe substance use disorder, you would need to meet 6 or above, 6 or more of the criteria above. So just a little bit of epidemiological data. So the scope of the problem. So this is looking at the interface on the left-hand side between substance use disorder and any mental health diagnosis. So you can see that there are about 35.9 million individuals with a mental health diagnosis versus 17 million that have both a mental health diagnosis and a substance use disorder diagnosis. So you can see that out of the 52.9 million adults that had any mental health diagnosis, it's a minority of them that also have a concomitant substance use disorder diagnosis. It looks a little bit different for the population that has a substance use disorder diagnosis. So about 37.9 million adults have a substance use disorder diagnosis. Of those, 17 million also have a mental health diagnosis. So only about 20.9 of those individuals with a substance use disorder diagnosis don't also have a mental health diagnosis. On the right-hand side is looking at individuals that have alcohol use disorder versus IDUD, which is an illicit drug use disorder. So for individuals who have alcohol use disorder only, that's about 54% of people who have a substance use disorder diagnosis. And then individuals that have an illicit drug use or an illegal drug use disorder diagnosis, that is about almost 30% of people with a substance use disorder diagnosis. And then about 16% of individuals with substance use disorder have both an alcohol use disorder diagnosis and an illicit drug use disorder diagnosis. On this slide, we are looking at the same stats from the previous pie charts on the last slide, but just representing them a little bit differently and including age on the left-hand side. So on the left-hand side, it breaks it up into those overall with a substance use disorder diagnosis versus those with an alcohol use disorder diagnosis and those with an illicit drug use disorder diagnosis. And you can see that the group that's most at risk, regardless of what type of substance use disorder diagnosis we're talking about, is the group of 18 to 25-year-olds. On the right-hand side is looking at past year substance use disorder diagnoses, and you can see that alcohol use disorder is the most common substance use disorder diagnosis, followed by marijuana use disorder. And then this is looking at substance use, so not specifically looking at a substance use disorder diagnosis, but rather just at use. And so you can see on the left-hand side that marijuana is the most commonly used substance, followed by, and this is again, illicit substances. So marijuana overall is illegal on the federal level. Alcohol is not included in this chart because alcohol is legal. So it's marijuana as the number one, followed by prescription opioid pain relievers. On the right-hand side is looking at use disorder, again, diagnoses, again, most common in 18 to 25-year-olds is marijuana use disorder. And then on the right-hand side, you can see the much smaller numbers associated with methamphetamine use disorder, which is going to be the topic we discuss today. This data is from the National Survey of Drug User Health from 2019. They did not yet break out data specific to methamphetamine from the 2020 survey. Here's looking at methamphetamine use over time, 2016 through 2019. Again, you see that there's more use in the 18 to 25-year-old group over time. However, you do see overall in the age group 26 and older that use has increased over time. This slide is from the National Survey on Drug User Health from 2020, and this is looking at stimulant misuse. So this is looking at both illicit stimulants as well as prescription stimulants. So it's a pretty complex diagram. It's looking at prescription stimulants, for example, such as Adderall. It's looking at cocaine and methamphetamine use. As well as a combination of all of those different varieties. So individuals who only use prescription stimulants, individuals who use both methamphetamine and cocaine, those who use both methamphetamine prescription and cocaine, etc. So it's a little bit of a more complex diagram than sometimes you see for other substances. So there are about 3.3 million individuals who only use and misuse prescription stimulants such as Adderall. There are about 3.3 million people who use cocaine only. There are about 1.5 million people who use methamphetamine only. And then there are about between 3 and 400,000 people who use both cocaine and methamphetamine, but not prescription stimulants, methamphetamine and prescription stimulants, but not cocaine. And then again, a group that uses all three groups. This is looking at substance use among adults greater than or equal to 18 years old by past year mental health diagnosis. So on the left-hand side at the top is looking at adults that had either uh, substance use disorder or any mental health diagnosis. That was on the first slide of epidemiology that I showed you. On the bottom, it's looking at this a little bit differently. It's looking at adults who had either a substance use disorder or serious mental health diagnosis. If we look at the population that has a serious mental health diagnosis, then a concomitant substance use disorder diagnosis is far more common than that larger pool of adults that have any mental health diagnosis. And so a small proportion of total those with a substance use disorder diagnosis also have a serious mental health diagnosis. And as I said, of the population with a serious mental health diagnosis, it's far more common that there's also a substance use disorder diagnosis. So when you look at the risk of having no mental health diagnosis versus any mental health diagnosis versus a serious mental health diagnosis, the more significant your mental health diagnosis is, the more likely it is that you also are using substances. And that relationship exists across substances, as you can see on the right-hand side. So regardless of which substance we're talking about, if you have a serious mental health diagnosis, you're using more than an individual with any mental health diagnosis, and you are then using more than individuals that have no mental health diagnosis. This slide is looking at methamphetamine use related to other substance use, as well as major depression episodes and serious mental illness. So, what you can see, and again, the common denominator on all these individuals is if they're in blue, that is showing any past year methamphetamine use. And if it's in red, then there's no past year methamphetamine use. So you can see that for individuals who have any of these risk factors, whether it's marijuana use, opioid misuse, heavy alcohol use, serious mental health diagnosis, a major depressive episode, or cocaine use, you can see that a pretty good percentage of them also have past year methamphetamine use. So more people have past year methamphetamine use in each of these categories than don't. So this is looking at the scope of the problem, looking at mental health and substance use disorder treatment gaps and the location of where somebody receives their substance use disorder treatment. So on the left-hand side, you can see that there's a high prevalence of both substance use disorder diagnosis as well as mental health diagnoses, but the treatment gaps in those systems are different. So if we look at a substance use disorder diagnosis, only about 11% of individuals with a substance use disorder diagnosis will ever access treatment for their substance use disorder diagnosis. In contrast, with respect to those with a mental health diagnosis, about 45% of those individuals will ever access treatment for their mental health diagnosis, so not as much of a gap. On the right-hand side, the most common location where individuals receive substance use disorder treatment is from a self-help group, such as a 12-step group. That is the same frequency as someone going to an outpatient treatment program. So again, self-help groups are very helpful to some individuals, but again, may not have the expertise that somebody might need and seek out in a more formal substance use disorder treatment setting. So it's important that we address overdose deaths when we're talking about methamphetamine use and methamphetamine use disorder. So this is just to remind us, what did overdose deaths look like pre-COVID-19? So on the left-hand side, you see the first three waves of the opioid overdose epidemic. So the first wave was due to prescription opioids, the second wave to heroin, and the third wave due to illicitly manufactured fentanyl and its analogs. And on the right-hand side is looking at psychostimulant overdose deaths pre-COVID-19. The blue line is representing that rise in overdose deaths due to cocaine, and the green line is showing the sharp increase in deaths due to methamphetamine. This is looking at psychostimulant overdose deaths with and without opioids involved. So the darker blue line is representing all overdose deaths involving psychostimulants, and the green line is showing all overdose deaths involving psychostimulants and opioids, and then the lighter blue line is representing all overdose deaths due to psychostimulants and no opioids. So you can see that the involvement of opioids along with both cocaine and methamphetamine has surpassed psychostimulant without opioid overdose deaths. This is also showing pre-COVID data. So this is looking at the percentage of overdose deaths involving psychostimulants with concurrent involvement of opioids by census region. So you can see that the Northeast region has the most or the highest percentage of overdose deaths involving psychostimulants with opioids involved. And again, this was pre-COVID-19. So this is looking at overdose deaths in 2019 and during COVID-19. So in 2018, for the first time, we had excuse me, in 2018, for the first time, we had a decrease in the total number of overdose deaths. However, starting in the fall of 2019, so in September 2019, a full 6 months before the start of the COVID-19 pandemic in the United States, you started to see a rise in overdose deaths. So this chart is representing the year between September 2019, when those overdose deaths started to rise again, and September of 2020. So during that time period, we saw an increase in the percentage of overdose deaths due to synthetic opioids, which is representing illicitly manufactured fentanyl and its analogs, by 55%. However, during the same time period, we saw a 30% increase in cocaine-related deaths and a 46% increase in methamphetamine-related deaths. This is looking at the trends in methamphetamine and fentanyl. So on the left-hand side, it's showing fentanyl in overdose deaths in blue and methamphetamine overdose deaths in that pink color. So methamphetamine was the top drug involved in overdose deaths in most of the western half of the US, while fentanyl dominated in the eastern half of the US. So that was pre-COVID-19. And what we've seen during COVID-19 is fentanyl has moved west and methamphetamine has moved east. So on the right-hand side is looking at data from January of 2019 to January of 2020. And those states that are in orange are showing the significant increase in stimulant-related overdose deaths. And New York is one of those states that had a significant increase in overdose deaths related to stimulants. I think by this point, everyone has seen the CDC overdose death estimates through December 2021. So that was the full calendar year from December 2020 to through December 2021 of 107,622 people. And that is the highest number of drug overdose deaths in a 12-month period. And overall, that was a 15% increase in deaths compared to 2020, and 2/3 of those deaths involve synthetic opioids such as fentanyl and its analogs, and there were a very significant number of deaths due to methamphetamine use. So this is looking at methamphetamine. On the right-hand side is what the chemical structure of methamphetamine looks like. And on the left-hand side is showing the mechanism of action and structure of methamphetamine. So what it does is that methamphetamine has effects on several neurotransmitters, including noradrenaline or norepinephrine, as well as dopamine. It's a complex methodology and mechanism of action compared to some other substances. It's far more complex than cocaine. So here are some of the properties of methamphetamine. It is synthetic. It is a longer lasting euphoria, so effects are felt from 8 to 24 hours after use. The half-life is 12 hours. The mechanism of action is mainly a dopamine release, though as I mentioned on the previous slide, it has other factors associated with its mechanism of action. Its medical use is less common, and there's greater neurotoxicity in commonly used doses than you find in other stimulants such as cocaine. So I mentioned dopamine at the beginning of this talk, and this is representing dopamine levels with methamphetamine use versus other substances. So as you can see on the left-hand part of the slide, which is looking at the increase in dopamine levels of amphetamine, you can see that it's a very high and very rapid increase. Um, if you look in comparison, if you look at the y-axis, the levels of dopamine are much, much higher in amphetamine or methamphetamine use than you see in the others. So the top of the scale on that left-hand side is 1100 for amphetamine. And if you look at the scales on the right-hand half of the slide, those y-axis scales are going up to 250, or in the case of cocaine, up to 400. So you can see that the release of dopamine is much, much higher with amphetamines than it is with other substances. So that makes methamphetamine particularly reinforcing compared even to other substances. So how is methamphetamine used? It has several routes of use, including insufflation or sniffing, smoking, ingesting or swallowing, injecting, or inserting rectally. Smoking and injection are the fastest routes of absorption. Absorption happens with smoking in 10 seconds, with injection drug use in 15 seconds, with insufflation or sniffing in 3 to 5 minutes, and with ingestion in 20 to 30 minutes. What are some of the immediate effects of methamphetamine use that are deemed positive by persons who are using methamphetamine? Increased alertness, concentration, and attention, decreased fatigue, improved cognition, increased libido, increased self-esteem, a sense of well-being, central nervous system psychostimulant and sympathomimetic effects with euphoric and pathogenic effects. So similar to using something like MDMA or ecstasy. Hallucinogenic effects, prolongs sexual performance, and increases sexual pleasure. What are some of the methamphetamine effects that would be perceived as negative by people using methamphetamine? Agitation, irritability, restlessness, insomnia, hypertension, dizziness, tachycardia, weight loss, decreased appetite, myocardial infarction or a heart attack, CVA, which is a stroke, arrhythmias, so abnormal heart rhythms of the heart, seizure, dental caries and poor dental hygiene, paranoia, anxiety, hyperactivity, movement disorders, auditory and somatic hallucinations, compulsive skin picking, difficult to heal skin lesions, poor hygiene or self-care, psychosis, rapid mood cycling, dehydration, hyperthermia at high doses, nausea, muscle or joint stiffness, hot flashes or sweating, illogical or disorganized thoughts, renal failure, impaired attention and memory, impulsivity, aggression, concentration difficulties, decreased cognitive function, sexual dysfunction, rapid eye movements, and breakdown of skeletal muscle. How does methamphetamine lead to chronic toxicity? It has to do with the excess dopamine that is released when someone uses methamphetamine. This causes auto-oxidation and reactive oxygen species. This leads to neuronal or nerve damage and gliosis, or basically destruction of cells in the brain, and excess glutamate transmission, which leads to excitotoxicity. So, something important is that we listen to our patients when they talk to us about some of the effects of chronic methamphetamine use. So, I mentioned them on the negative symptom slide as immediate effects, but also they can be chronic effects due to methamphetamine use. So, some of these effects may be anxiety and depression, again, that's lasting, aggression, social isolation, psychosis, psychomotor dysfunction, and withdrawal symptoms, anhedonia, irritability, fatigue, and intense cravings. So consider symptom-based pharmacological interventions, and those decisions are based on the risks of treatment versus no treatment. What about methamphetamine use and psychosis? So the increase risk for psychosis is dependent on the frequency of the methamphetamine use. So there's a 2 times risk for psychosis in recreational users and a 5 times risk in regular users compared to non-users. And often it unmasks schizophrenia. So for individuals who are using methamphetamine anywhere between 1 and 15 days in the past month, their odds ratio for developing psychosis is 4, or 4 times someone not using methamphetamine. If you're talking about an individual who is using methamphetamine greater than or equal to 16 days in the past month, then their odds ratio for developing psychosis is 11.2, or 11.2 times the risk of someone who is not using methamphetamine. Also, this risk is magnified when you're using other substances in addition to methamphetamine, including alcohol and cannabis use. So, what does this look like? It's a loss of touch with reality. It can include auditory hallucinations, as well as persecutory and reference delusions, so similar to an individual who has schizophrenia. The psychotic symptoms may persist or recur spontaneously even after prolonged abstinence from methamphetamine use. Methamphetamine users with psychosis have more severe impairment than those without psychosis, more health service utilization, and a poorer prognosis overall. So we know that methamphetamine use is associated with affective distress and cognitive function. So how does this present in our patients? Estimates range for the range in these symptoms from 30 to 80% for all substances. This was a study that looked cross-sectionally at about 650 clients seeking treatment. Most of them were using alcohol, 60%, 19% were using cannabis, and 15% were using stimulants. The mean age was 40 years old. The overall prevalence of affective distress and cognitive function in this cross-sectional study was 31%. It was particularly noted in marginally housed youth, 40% of whom were mildly cognitively impaired, and 16% were moderately to severely cognitively impaired. What did it look like in patients? They were more distressed. They had more impaired attention. They had more psychotic symptoms, including paranoia. They had impaired decision making, and you had to focus on very small and immediate rewards to engage them in care. They had poor impulse control, decreased working memory. They were prematurely old, and there were basically neurotoxic results to their dopaminergic or dopamine and serotonergic or serotonin systems in the brain. So they had irreversible loss of nerve terminals and or nerve bodies, and they had impaired judgment. So, when we think about the positive symptoms of psychosis associated with methamphetamine use, it is similar to individuals with a diagnosis of schizophrenia. So, those quote unquote positive symptoms, it doesn't mean positive experience to the patient, but positive meaning sort of an add on, an increased symptom compared to baseline. So, those positive symptoms include suspicion, unusual thought content, hallucinations, and bizarre behavior. Most episodes of psychosis with methamphetamine use are brief, so hours to days. However, these episodes can persist for months and recur even during periods of non use, including long periods of non use. So we have to ask ourselves, is there a compelling reason to wait to treat the symptoms? We should consider use of antipsychotic medications such as aripiprazole or risperidone, again, weighing the risks versus benefits for that individual patient. So let's look at a more comprehensive picture of neuropsychiatric harms associated with methamphetamine use. Stroke, so there's a fivefold increase in the risk of hemorrhagic stroke due to methamphetamine use. There's, in general, neurocognitive impairment. So, learning, executive functioning, memory processing speed, and language skills are affected by methamphetamine use. With respect to Parkinson's disease, there's up to a three times increased risk of acquiring it with methamphetamine use. Though, again, very few cases, but there is an increased risk. There's a risk of seizures with acute use of methamphetamine, and there are the psychotic effects that we've talked about. So these have a frequent incidence rate anywhere between 13 to 27% and 15 to 30% of first break psychotic episodes with comorbid stimulant use. So just to be sure we're all on the same page, what is executive function? So, to put it in layperson terms, it's considered the air traffic control center for the brain. It oversees working memory, inhibitory control, mental flexibility, and in fight, flight, or freeze mode, where the executive function is impaired, this can lead to, for example, in youth, poor school performance, problems with peers, and problems with authority figures. So, as we talked about a couple slides back, with methamphetamine use being associated with affective distress and cognitive function, how can this manifest itself when we're looking at different domains? So, on the left hand side is looking at the neuropsychological dysfunction being at the center. And what can that have an effect on? It can have an effect on methamphetamine use itself. So, a person might want to use more to cope with the dysfunction that they're feeling. That can lead to sleep disturbance, that can lead to trauma, being more vulnerable to trauma, that can lead to increased fight or flight response, which can lead to increased affective distress and increased methamphetamine use. With respect to looking at some of the risks that are at play or some of the potential harms that could happen to that individual, you layer on these different factors: childhood trauma, a mood disorder, PTSD, risky sex, frailty, HIV and hepatitis C, cognitive dysfunction, and meth use. So, how do we differentiate methamphetamine psychosis from other causes? It can be difficult. There is definitely an overlap in symptoms. There are fewer negative symptoms. So negative symptoms, or thinking of it, if we compare it to a diagnosis of schizophrenia, it's less as opposed to positive, which is more. So there are fewer negative symptoms with methamphetamine psychosis. There's less paranoia compared with schizophrenia. There's less flat or blunted affect and less conceptual disorganization. You also have somewhat better social functioning compared with persons with schizophrenia. And the thought disturbance piece of the methamphetamine psychosis may respond to neuroleptics or antipsychotic medications. So, how do you differentiate methamphetamine psychosis as a primary psychotic disorder versus a substance induced psychosis? So, in a primary psychotic disorder, what does that look like? Symptoms substantially in excess of expected given type, amount, or duration of use. The history of psychotic episodes is not substance related. Psychotic symptom onset precedes the onset of substance use, and psychotic symptoms are ongoing even 1 month after cessation of use or acute withdrawal. So that would again be to support a psychotic disorder diagnosis such as schizophrenia, or another diagnosis on the schizophreniform spectrum. When you have a substance-induced psychosis, you have prominent, hallucinations or delusions. Symptoms develop during or soon after intoxication or withdrawal. Psychotic symptoms are not part of any other psychotic disorder that is not substance-induced, and psychotic symptoms do not only occur during a delirium. How do we screen for cognitive dysfunction? We have brief tests that we can use, such as the MoCA, which has 8 domains that are assessing attention, concentration, and executive function. There's the mini-cog, which looks at memory, visuospatial, and executive functions. Formal neuropsychological testing is the gold standard, but that's usually only possible with a period of non-use. Some of the study instruments are the CANTAB, which is the Cambridge Neuropsychological Test Automated Battery, the LNST, or letter number sequencing test, the RAVLT, the Ray Auditory Verbal Learning Test, or the Stroop Color Word Test. So to give a sense of how social cognition is impaired with methamphetamine use, I'm going to read this quote. The mental operations that underlie social interactions, including perceiving, interpreting, and generating responses to the intention, disposition, and behavior of others. So, with respect to the theory of mind, the cognitive ability to make inferences about others' mental states and to use them to understand and predict behavior is altered. Also, there's an effect on facial expression recognition. So this is impaired independently from the theory of mind. And people who are using methamphetamine regularly often have difficulty interpreting facial expressions, and they associate faces with aggressive behavior, even when that's not the intention of the person who they're trying to interpret their behavior. So, does brain function improve with cessation of methamphetamine use? So, there is a partial restoration of striatal dopamine pathways following discontinuation of methamphetamine use. The loss does persist for months to years, and sustained decreases in dopamine transporter or DAT levels in multiple brain areas, including the nucleus accumbens and the prefrontal cortex. Serotonin reduction in the thalamus, the cortex, the cerebellum, and the caudate putamen improves with discontinuation of methamphetamine use. So while you do see a partial restoration and you do see improvement in these areas of the brain, does this translate to clinical improvement? So neurocognitive performance worsens with acute withdrawal from methamphetamine. After 6 months, cognitive performance partly improves with respect to attention, concentration, and cognitive flexibility. Longer term abstinence or sobriety leads to partial normalization. So you will have lower affective distress over time and better neuropsychological functioning over time. An improvement in depression or in other psychiatric comorbidities may further assist in cognition improvements. So, very briefly, I'm going to address the BEAT methamphetamine intervention for emergency department patients with methamphetamine psychosis. So this is an algorithm that is used for individuals who present to emergency departments with methamphetamine-induced psychosis to try to improve their outcomes. So this protocol was studied in an urban safety net health system. And the protocol had ways of doing early identification and treatment of methamphetamine psychosis. And so they did a comparison between individuals who received this beat meth protocol versus ED patients with methamphetamine psychosis who were discharged without implementation of this pathway. So the results were that those patients who were treated with the beat meth protocol were 3 times more likely to attend an outpatient specialty addiction appointment in the 30 days after discharge than comparison patients. Subsequent ED utilization was common among all patients, and there was no significant difference in 30-day emergency department return rates between the two groups. So again, their conclusions were that this is perhaps an interventional framework to identify, manage, and treat people in the ED with methamphetamine psychosis, but obviously they would need to do more studies to determine if it's effective in longer term outcomes. So, what are some of the possible treatment options for individuals with methamphetamine psychosis? So, antipsychotic medications are likely effective. These include olanzapine, haloperidol, and quetiapine. These are helpful for treating anxiety and insomnia that's associated with psychosis as well. Uh, Refraining from methamphetamine use does help reduce psychotic symptoms. They generally resolve within 1 week. And then cognitive behavioral therapy, and including other behavioral therapies such as contingency management and the matrix model, also are have some efficacy in treating methamphetamine psychosis. So, what are some of the motivations for drug use with methamphetamine? There are several domains. There's the physical domain. So, the physical sensation, non-sexual, associated with methamphetamine use, as well as sexual sensation and the facilitation of sex. There's the emotional domain, so emotional enhancement, emotional equivalence, and cognitive disengagement and emotional escape associated with methamphetamine use. And there's the social domain, social interaction and overcoming social inhibitions with methamphetamine use. Methamphetamine is commonly used with other substances. This is not an exhaustive list, but some of them include other amphetamines, such as prescription amphetamines, cannabis, cocaine, either powder cocaine or crack, ecstasy, which is also known as MDMA or Molly, GHB, heroin, synthetic cannabinoids such as spice or K2, ketamine, amyl nitrite or poppers, alcohol, nicotine, fentanyl, prescription opioids, benzodiazepines, and other sedatives, and erectile dysfunction drugs such as Viagra or sildenafil. This study was looking at methamphetamine and concomitant opioid use. So this was looking at methamphetamine use by opioid use history, and this was looking at data between 2015 and 2017 in the National Survey of Drug User Health. So if you look at this graph, it's showing past month heroin use. Those are represented by the circles. And then it's looking at past month non-medical prescription opioid use, which is represented by the triangles. Past year non-medical prescription opioid use disorder with the squares. And then the filled symbols are showing where it was significantly different from 2015. So the dotted line represents substance use disorder variables, and the solid lines represent past month variables. So what we're seeing over time is we're seeing an increase in past month between these years, 2015 and 2017, an increase in past month heroin use, an increase um, in opioid prescription use, and an increase in between 2015 and 2016. And we're seeing sort of a flat leveling of prescription, non-medical past month prescription opioid use. And and essentially what it's showing us overall is that over time, we're seeing an increased use of opioids, particularly heroin at that time. And again, that would be substituted with fentanyl now, over time compared to historically when methamphetamine use was less commonly used with opioids. So there's a complex interplay between methamphetamine use, men who have sex with men, and sex. So what's the connection? So there's a synergism between illicit substance use and unprotected sex. And I'm only going to address this pretty briefly, but I think it's important to understand this connection. So it's facilitated by environmental factors and norms. So sexual and social venues. So sexual meaning the role of sex in subgroups' lives, and also by sex networking apps such as Grindr, for example. It's fueled by psychosocial burdens. So there are many psychosocial burdens: racism, homophobia, trauma, stigma, discrimination, transphobia, minority stress effect, misogyny, intimate partner violence, comorbid mental health, which could include major depression disorder, PTSD, generalized anxiety disorder, ADHD, psychological vulnerability, unstable or unsafe housing, homelessness, and victimization. It heightens the likelihood of unprotected sex, so anal sex, oral sex, and quote extreme unquote sex. Also sexual compulsivity, an increased number of partnering. So group sex, sex marathons, fisting, S&M, these all can lead to rectal trauma and bleeding. Decreases sexual inhibitions and affects judgment about sexual partners and practices and risks, reduced condom use, development of erectile dysfunction or sexual performance anxiety in response to methamphetamine use may lead that individual to engage in more receptive anal sexual intercourse. A reduced desire for quote sober unquote sex, increased incidence of sexual assault, and an overrepresentation of HIV among men who have sex with men. It also enables the transmission of bacterial and viral pathogens such as HIV, Hep C, hepatitis B, and sexually transmitted infections, including HSV or herpes, HPV or warts, gonorrhea, syphilis, chlamydia, NGU, and LGV. There's a risk of conversion to HIV that is heightened by the use of drug combinations. So when individuals are using stimulants only, their odds ratio is almost 3 compared to someone not using stimulants. And if someone is using 3 drugs, such as stimulants, amyl nitrate, and erectile dysfunction drugs, that brings their odds ratio up almost to 9 as far as a risk of getting seroconversion to HIV. So the risk for seroconversion to HIV is similar between those who use drugs via injection drug use and those who use psychostimulants, but not via injection drug use. So as I mentioned in the previous bullet point, this risk increases with the number of drugs used. So the odds ratio is 3 with the use of one drug, but it jumps to 9 with the use of 3 drugs, regardless of the drugs used, and is highly associated with psychostimulant use before sex. So if we look at methamphetamine use and HIV risk, and we look at young MSM, this was a sectional analysis done in 8 US cities. There were almost 600 adolescent boys and young MSM in this study. Recent methamphetamine use was associated with a history of STIs in almost 52%, 2 or more sex partners in the last 90 days, that was almost 86%, and sex with someone who has HIV, almost 33%. Recent methamphetamine use was also associated with a history of homelessness, almost 72%, and less likelihood to be attending school currently, almost 36%, and polysubstance use was common. This study was looking at methamphetamine use among men who have sex with men in New York City by race ethnicity. The point in this slide is to show you over time how that has shifted. So in 2004 and in 2008, more white MSM were using crystal meth than men from other race ethnicities. So they're tracking here African Americans and the Latinx population. But that shifted initially for Latinx population in 2008, and then it shifted to African American MSM in 2011. And by 2014, both Latinx and African American MSM were more commonly using crystal meth than white MSM in New York City. And this is looking at risky behaviors with methamphetamine use. So TINA represents methamphetamine and no TINA represents no methamphetamine. So the likelihood of having condom-less sex, regardless of HIV status, increased if methamphetamine were used by the individuals. So this is just a reminder that there are no FDA-approved medications for any other substance use disorders besides opioid use disorder, alcohol use disorder, and tobacco use disorder. But having said that, there are other strategies for treating other SUDs. So different forms of therapy, such as cognitive behavioral therapy, contingency management, which is a reward-based system combined with community reinforcement. Community reinforcement uses recreational, familial, social, and vocational reinforcers to make a non-substance using lifestyle more rewarding than substance use. And there are off-label use of medications that do have some data to support their effectiveness with patients. So what are some of the behavioral interventions for the treatment of methamphetamine use disorder? Cognitive behavioral therapy plus coping with symptoms of psychosis. The matrix model, contingency management and community reinforcement, motivational enhancement therapy, 12-step facilitation, motivational interviewing. Behavioral interventions may be combined with 12-step support or smart recovery. And you want to consider the level of care that that individual you're working with may need. Maybe it's an intensive outpatient setting, or maybe it's a residential setting. So when we're communicating with our patients and working with them on supports uh, with individuals with methamphetamine use disorder, it's important to keep these points in mind. Be patient, simplify goals, repeat and reinforce simple messages, offer short-term rewards and positive feedback, identify cognitive dysfunction, and refer to community supports. So what are some of the guiding principles of the matrix model? First is respect. So building a strong relationship between the counselor and the client using mutual respect. Follow through on structure and expectations. So the client must embrace the entire program and meet expectations. Quality educational content, varied treatment approaches. So this could include motivational interviewing and cognitive behavioral therapy. Reward and encouragement. So rewards for desired behaviors, extinguish negative behaviors. Engagement and education. So particularly for youth and young adults, including the entire family. Participation in self-help and community-based programs. Strongly encourage participants to engage in mutual help programs. So as I mentioned, that could be 12-step programs, or it could be something like Smart Recovery. And periodic drug testing or urine toxicology testing. So the Matrix model is a 16-week program. It involves individual counseling as well as group counseling on early recovery skills. So 8 sessions over the first month, focusing on 2 concepts: individual power to increase likelihood of abstinence or decreased use, importance of community-based recovery groups, another group on return to use or relapse prevention, beginning and end of each week for 90 minutes, identifying signs for return to use in order to prevent. And some topics discussed may include that return to use may be predictable, it may involve shame and guilt, and identifying triggers. Another group on family education, and another group on social support that begins in the 3rd month and continues for 36 weeks, recognizing that people who use drugs often lose or never had the ability to interact socially in a healthy way. What about contingency management for methamphetamine use disorder? So this is based on operant conditional modeling of substance use disorder. It has 3 key aspects: the amount of reinforcement per behavior, the immediacy of delivery, and a magnitude of reinforcement. Meta-analyses show that contingency management is effective in 61% of treatment episodes versus 39% for other interventions. It has been shown to be effective across substances, including alcohol, opioids, cocaine, methamphetamine, marijuana or cannabis, and benzodiazepines. This is looking at that meta-analysis, systematic review. So they looked at 27 studies, 15 of which were randomized controlled trials. And what they saw was an improved treatment engagement and affect, reduced sexual risk behaviors, reduced methamphetamine use, and increased engagement in substance use disorder treatment and in community programs. What about motivational interviewing for methamphetamine use disorder? So SAMHSA has identified motivational interviewing as having strong evidence for people with stimulant use disorder. Evidence includes increased willingness in meth-using adolescents to enter treatment, and decrease alcohol use in women with co-occurring alcohol and meth use disorder, and a decrease in severity of psychiatric symptoms for people with both a mental health diagnosis and a stimulant use disorder diagnosis. This study looked at psychosocial and pharmacologic interventions for methamphetamine use disorder. So what I'm going to do is focus on the conclusions of this study. So these looked at the management of patients with methamphetamine use disorder and what they termed as problematic methamphetamine use, or PMU. And what they did is they utilized a variety of platforms to identify searches that met their eligibility criteria for treating individuals with methamphetamine use disorder or problematic methamphetamine use. And who they included were individuals who had at least 3 or more months of follow-up. So what they found is that that overall, that there are some studies that do show some effectiveness of both psychosocial and pharmacological interventions for methamphetamine use disorder and problematic methamphetamine use. But what they found was that there's not a consistent methodology across the studies, which I'll get into a little bit more when I talk about off-label use of medications, and that we need more studies to compare treatments, such as having a network meta-analysis across studies. So I'm going to move into the section of discussing off-label use of medications for methamphetamine use and methamphetamine use disorder. So just a couple disclaimers. So while there are no medications approved by the FDA for the treatment of cocaine and methamphetamine use disorders, several medication classes have preliminary evidence for potential benefits. So again, off-label use of medication should be provided along with a psychosocial plan for individuals who are able and willing to engage in those psychosocial treatments. Medication should be discontinued if patients are experiencing no clear benefit after a reasonably adequate trial of the off-label use medication. So again, more disclaimers for the use of off-label use of medications. Toxicology panels should include opioids and fentanyl, even for individuals who report only cocaine and or methamphetamine use, in order to be able to inform them about their presence in their substances in case they are not using, so you can do harm reduction interventions. Providers should regularly and carefully assess patients with cocaine or methamphetamine use disorder for treatment progress, adverse effects, and potentially high risk or high harm behaviors, such as self-harm, suicidal ideation, high risk substance use or violence risk. And be sure to do clear documentation in the medical record. And when off-label medications are prescribed, providers should document carefully that they have educated patients on the risks, benefits, alternatives, the evidence for using the medications, and the fact that the medications have not been FDA approved to treat the indication for which they are prescribing them. Providers should consider having patients sign treatment agreements detailing this information. Again, more just a roles and responsibilities going both ways between the provider and the patient, and the expectations for treatment before starting off-label medications. So what are the goals of treatment versus endpoints in clinical trials? And sometimes these are very, very different. So what could be considered some alternative endpoints for treating stimulant use disorder, including methamphetamine use disorder? Reduced use, controlled use, decreased cravings, improved cognitive function, improved sleep, or other goals. So, unfortunately, often those are not what are measured in clinical trials. The FDA guidance on endpoints recommended primary efficacy endpoint is a decrease in drug use based on a comparison of responders. Commonly used threshold to define a treatment responder is abstinence, but abstinence is not required as an endpoint. So other thresholds besides abstinence are acceptable. So what you would want to show is that the drug use pattern is changed by adding a medication so that you could be able to show clinical benefit. So first, the OASAS MAP or Medical Advisory Panel did create an off-label pharmacotherapy for psychostimulant disorders guidance document. So it was a summary of the evidence for medications that they currently recommended for off-label use. So some of the medications that were included in that document include naltrexone, 50 to 100 milligrams by mouth daily, topiramate, 200 to 300 milligrams total divided twice per day, bupropion SR, 150 milligrams by mouth twice per day, or the XL formulation, 300 milligrams by mouth once daily, sertraline, specifically for cocaine use, 200 milligrams by mouth daily, and mirtazapine, specifically for methamphetamine use, 30 milligrams by mouth at bedtime. With respect to the use of stimulant medications for treating psychostimulant use disorders, various formulations, including methylphenidate, both the ER and SR formulations, mixed amphetamine salt, the ER formulation, dexamphetamine, dextroamphetamine SR, modafinil, These are all controlled substances and thus require close monitoring of patients as these medications can be misused. They may be especially helpful for patients with a stimulant use disorder and concomitant ADHD. So there have been many trials of medications looking for success for the treatment of methamphetamine use disorder. So what are some of the medications that have had positive results or are under consideration? Bupropion, which is better in low severity users of methamphetamine, mirtazapine, naltrexone, methylphenidate, D-amphetamine, particularly for cravings and withdrawal, topiramate, which is better if a person is not using at treatment entry, and bupropion plus naltrexone. And what about those medications that have had negative results? So just a caveat about negative results. Um, it's a trial in which a new medication was not superior to placebo, but an active control was, or a trial in which the new medication was not superior to placebo, but there was no active control. So negative results does not mean no results, and it may work in your individual patient. So some of the trials with negative results are imipramine, diazepam, ondansetron, tyrosine, fluoxetine, sertraline, paroxetine, aripiprazole, gabapentin, N-acetylcysteine, and modafinil, again, better in high severity users compared to low severity users. So what are some of the problems in the studies for medications for methamphetamine use disorder? They're often underpowered, meaning they don't have enough participants in the study to be able to show a difference between the treatment groups. They're often high attrition rates, so people frequently drop out of the clinical trials. So bupropion may be more effective in individuals with use disorder with less severity, and it may be better in individuals with comorbid depression and in males compared to females. There is low strength evidence that methylphenidate and topiramate may facilitate a reduction in substance use. Topiramate, as I mentioned on the previous slide, is better in effect if there's a negative urine drug screen at baseline when the person starts the medication. So this is a challenging slide to read, so I recommend that people blow it up and look at it in more detail. So this is looking at the tradition of placebo in addiction medicine studies, specifically methamphetamine studies, and it goes through the variety of different studies that have had placebo as a control. So when we think about doing studies for difficult to study substances like methamphetamine, it may be helpful to think about using adaptive designs to do that research. So adaptive designs can lead to more efficient trials. There are fewer patients that may be required for the study to show effect. It reduces the chance of an underpowered trial. The patient population most likely to benefit from a treatment may be identified by eliminating the noise of the placebo part of the trial. Treatment effects may be estimated with greater precision, and adaptive designs, really for the researchers themselves as well as for the participants, may be more exciting to design, implement, and interpret. It's not to say they don't have their challenges. So let's go over some of the data for use of pharmacotherapy with methamphetamine use disorder. So first is bupropion. So this was a randomized trial of bupropion SR 150 milligrams daily versus placebo for 12 weeks at methamphetamine users with less than daily methamphetamine use. Okay, so when they looked at end of treatment adherence, adherence was quite low. So adherence in the bupropion group with an N of 41 was only 29%. And, sorry, end of treatment abstinence. And then if they look at the placebo group, it was only 14%. So that was not a clinically significant value. But Only 32% of, or 13 of 41 of the bupropion participants were deemed medication adherent via week 6 plasma bupropion levels. So if someone were adherent with the medication, it was strongly associated with end of treatment methamphetamine abstinence. So when they did a subgroup analysis and just looked at the patients who were in the bupropion group who actually took their medication, then the end of treatment abstinence was 54%, as opposed to 18% in the non-adherent group of people in the bupropion group. And that actually was clinically significant. So really, bupropion may be an effective strategy for patients if they indeed are adherent with taking the medication. This study looked at the use of mirtazapine. So they used mirtazapine, 30 milligrams per day, in individuals with methamphetamine use disorder who were also men who have sex with men. The methamphetamine positive urine test results were lower for the mirtazapine group compared to the placebo group, and that was statistically significant. They also noticed decreased HIV risk behaviors associated with those that were on mirtazapine. So their a proposed mechanism of action is that they think that dopamine and norepinephrine are enhanced via blocking the presynaptic alpha-2 adrenergic and or 5-HT2C, which are serotonergic receptors. So again, mirtazapine may be a viable option for patients using methamphetamine. The next trial is for methylphenidate. So this was 90 individuals seeking treatment for methamphetamine use disorder. They had 10 weeks of active medication with methylphenidate, which was titrated up to 54 milligrams per day versus placebo. And this was followed by a 4-week single-blind placebo phase. They also had a cognitive behavioral therapy platform with motivational incentives. And they looked at methamphetamine negative urine drug screens. So methylphenidate was associated with significantly fewer self-reported days of methamphetamine use over the active treatment period compared with the placebo group. In the methamphetamine users with greater than 10 days use in the past 30 days at baseline. So again, not the primary outcome. The methylphenidate group reduced methamphetamine use greater than placebo from baseline to end of the active phase. So they went from 6.5 days versus 3.5 days. There was no difference in the proportion of positive urine drug screens across the active medication period. The methamphetamine group had fewer methamphetamine positive urine drug screens at week 14. The methylphenidate group had lower craving scores at weeks 10 and 14. So again, not super robust, but there may be a subset of patients with methamphetamine use disorder that may get decreased use by using methylphenidate. So this is looking at naltrexone for the treatment of methamphetamine use disorder. So naltrexone has been shown to reduce subjective effects of methamphetamine and return to methamphetamine use. So this was an open label naltrexone extended release plus bupropion in 49 what they termed severe methamphetamine users for 8 weeks, yielded 11 responders. So 6 out of 8 had methamphetamine negative urines in the last 4 weeks of medications. So I am going to go to the next slide where we go into a little bit more detail on this. So this is looking at bupropion and naltrexone. So this is a multi-site, double-blind, 2-stage, placebo-controlled, sequential parallel comparison study. And this looked at the efficacy and safety of extended release, so injectable naltrexone, at a fixed dose of 380 milligrams every 3 weeks, plus oral extended release bupropion, 450 milligrams per day in adults with moderate or severe methamphetamine use disorder. They looked at a response over 12 weeks among participants who received extended release injectable naltrexone plus oral extended release bupropion, low or high dose versus placebo. And what they found was that while they weren't super robust, again, findings, they did find that there was less methamphetamine use in the individuals who received bupropion and naltrexone dual therapy. So what is a summary of some of the off-label pharmacotherapy options for methamphetamine? So some options include bupropion 3 milligram, 100 milligrams per day, topiramate 300 milligrams per day, naltrexone 50 to 100 milligrams per day, mirtazapine 30 milligrams per day, methylphenidate 54 milligrams per day, or the combo of the injectable naltrexone plus bupropion that I mentioned on the previous slide. Some safety considerations to think about and discuss with patients are seizure threshold, history of prescription stimulant use disorder, and other medical, psychiatric, and substance use comorbidities. So this was looking at a systematic review and meta-analysis of agonist treatment for stimulant use disorders. So this looked at almost an N of 3,000 patients. They looked at 38 randomized, double-blind, placebo-controlled, parallel design studies of modafinil, methylphenidate, or amphetamines. And what they found was that treatment increased rates of sustained abstinence and duration of abstinence, regardless of which treatment we're talking about. It was less effective for urine toxicology results, but remember, we're really looking for patients to have increased functionality in their lives and better quality of lives. We're not looking at abstinence as the goal. And so prescription amphetamines for sustained abstinence in patients with cocaine use disorder, they did not find it to be as effective in those with methamphetamine use disorder, but you had to use higher doses of the prescribed amphetamines than you would in standard treatment of, say, ADHD, for example. So what about if someone has an ADHD, SUD comorbidity? So they have methamphetamine use disorder and they have ADHD. So there's reduced effectiveness of standard treatment in individuals with these comorbidities. There's earlier onset and faster transition to substance use disorder from substance use, more complex and chronic patterns of use, increased polysubstance use, greater comorbidity and with other psychiatric conditions, so antisocial and borderline personality disorders, anxiety disorders, bipolar disorders, and post-traumatic stress disorder. There's greater complexity and treatment challenges. So these folks often need more frequent treatment, have more difficulties with achieving decreased use or abstinence, reduced quality of life, more professional, social, and personal problems, and lower effectiveness of standard dose pharmacotherapy for ADHD. So what are some medications that may be effective in treating this combination? So when we look at medication effectiveness in reducing ADHD symptoms, the mean standardized effect size is between 0.4 and 0.5. So studies show promise with regard to substance use disorder outcomes in secondary analyses. So they're not necessarily the primary analysis, which may be looking at decrease in ADHD symptoms, but it'll come up in the secondary analyses. So there have been 2 studies with higher doses of methylphenidate, up to 180 milligrams per day, that showed a decrease in ADHD symptoms and a decrease in the reinforcing effects and the use of cocaine and amphetamines and other substances in adult stimulant-dependent ADHD patients. Robust doses of mixed amphetamine salts in the extended release formulation, 60 and 80 milligrams per day, showed substantial reductions in both ADHD and substance use in patients with cocaine use disorder with ADHD. Atomoxetine resulted in a significant reduction in ADHD symptoms and was associated with a decrease in alcohol cravings and consumption. There's some evidence for the effectiveness of bupropion to reduce ADHD symptoms in those with an ADHD SUD comorbidity, but results have been contradicted in small controlled studies, so showing no effect over placebo. Guanfacine extended release is an effective and approved treatment for children and adolescents with ADHD with mild to moderate adverse effects, and the most common effect is sedation. There's preliminary evidence that shows that guanfacine may be a well-tolerated treatment option for adult ADHD, but more research is needed. Pemoline was also shown to have positive effects for ADHD, but not on substance use. And as I mentioned on a previous slide, prescribing stimulants to individuals with a stimulant use disorder is somewhat controversial. Many clinicians are reluctant to prescribe standard ADHD treatments to individuals with SUD. There is a potential risk of misuse and diversion with prescription stimulants, but we also know that outcomes for individuals with comorbid ADHD and SUD are less successful without concomitant treatment of the individual's ADHD with appropriate medication. Prior studies have not demonstrated severe complications or increases in substance use when prescribing stimulants in this patient population. And study designs do not always replicate real-world practice standards, for example, with respect to visit frequency. Adverse events are not increased in ADHD patients with substance use disorder compared with ADHD patients without substance use disorder. So if we're going to prescribe to individuals with the comorbidity of ADHD and a stimulant use disorder, long-acting formulations, particularly osmotic release oral system formulations of methylphenidate and lisdexamfetamine, may have better, meaning lower rates of misuse and diversion compared to immediate release preparations, and risk of misuse becomes relatively lower when medications are prescribed under monitored conditions. And as I mentioned, the treatment of ADHD can be useful to reduce ADHD symptoms without worsening the substance use disorder and should not be avoided. And we know that individuals' substance use disorder often gets worse when their ADHD is untreated. So medication may have more positive effects when combined with psychotherapy. So you can combine pharmacotherapy with one of the behavioral interventions for ADHD and substance use disorders, such as integrated cognitive behavioral therapy. And clinicians should consider therapy with a focus of overlapping symptoms as part of a multimodal treatment approach. And ADHD pharmacotherapy by itself is generally not effective in reducing the use of substances and is associated with a higher frequency of adverse effects and treatment discontinuation. So, why is the stimulant treatment literature so confusing and what is missing? So there's a limit in generalizability of the data. So often women have been excluded from these studies. So they're about 25% of the amphetamine trials. The majority are males in the studies at over 70%. And often comorbid mental health diagnoses or concomitant medications for comorbid health diagnoses are used as exclusion criteria from including those individuals in these studies. So it is somewhat difficult to reach conclusions regarding efficacy of these medications. So again, there are methodological differences between the clinical trials that have been done for methamphetamine use disorder. So again, are we looking at facilitating abstinence, or are we looking at trying to decrease risk for return to use, like in high users versus low users? Are we using a psychotherapy platform in addition to the pharmacotherapy? How are we assessing adherence? How are we making our dosing choices? Are we going above standard doses? Are we including or excluding those with opioid use disorder? Because generally that leads to greater negative results for stimulant use disorders. Also, there's a broad selection of outcomes and measures across studies, so it's hard to compare studies to one another. So we need studies that examine the efficacy of pharmacotherapy alone versus the efficacy of combined medication and various forms of behavioral interventions. So again, to just kind of sum it up with the treatment summary, what treatments show promise? So the trials that I've indicated in red had at least 100 people in those clinical trials. So methylphenidate is for moderate to high use and frequent users, or those with ADHD. Dextroamphetamine, again, but with fewer than 100 people. Modafinil, if people are adherent. Bupropion in low-level users. Naltrexone, and you may need to use this for return to use prevention and at high enough doses. Topiramate for low-level methamphetamine users. Mirtazapine in combination of extended release naltrexone and bupropion. So next, I wanted to just talk about syndemics theory when we're talking about methamphetamine use disorder. So we talked about that complex interplay between sex and men who have sex with men and methamphetamine use. So let's talk about syndemics theory. So the complexities involved in methamphetamine use, particularly within potentially marginalized patient populations, including men who have sex with men, bisexual men, transgendered persons, HIV positive persons, etc., requires a complex prevention and treatment agenda that recognizes psychosocial vulnerabilities and stigma, is sex positive, and addresses substance use in a harm reduction framework. Unfortunately, it's challenging to combine all those things to address all the complexity of individuals. So the HIV prevention world often focuses on sexual health for gay and bisexual men, while the SUD treatment world often ignores sexuality in its entirety. So neither world may recognize the unique psychosocial vulnerabilities that these complex populations face. So how about some safety tips for methamphetamine users? So what is overamping? This is a negative reaction to using stimulants. It's different from overdosing, but it can be life-threatening. So symptoms can include chest pain, dyspnea, or shortness of breath, hypertension or high blood pressure, tachycardia or rapid heart rate, hyperthermia, so excessive heat, anxiety, paranoia, and aggression. So what are some tips to prevent it overamping? Stay hydrated, replenish electrolytes, seek medical attention, find a quiet and calm space, protect the head in case of seizure. And what about for preventing overdose? So persons will overdose if exposed to enough opioids, whether the opioid exposure is intentional, so speedballing, mixing heroin, for example, with stimulants, or mixing fentanyl with stimulants, or unintentional, so fentanyl and its analogs added to the stimulant supply. So tips to avoid overdose: test your drugs with fentanyl test strips. So federal funds can be used to purchase fentanyl test strips. You also need to test a little bit differently with methamphetamine, which I'll go over in a minute. Avoid mixing drugs, use smaller amounts, carry naloxone so somebody can reverse an overdose in you if you do go into an unintentional overdose. Providers should dispense or prescribe naloxone to all persons who are actively using, regardless of the substance used. So rare exceptions, if someone's only using alcohol or marijuana. Don't use alone. There's the Never Use Alone overdose prevention call-in line. Advise regarding mail order naloxone and other harm reduction supplies directly sent to the homes of people who use drugs at www.nextdistro.org. That is in New York State, outside of New York City. And consider prescribing buprenorphine for those at high risk of overdose. Just to remind you of the New York State Department of Health guidance document, Build a Safety Plan, that you can order online for free. Again, overdose preventions that I mentioned, practices, so virtual naloxone trainings, mail order naloxone and other harm reduction supplies directly to the homes of people who use drugs at www.nextdistro.org, and the Never Use Alone prevention call line. So that individual who is a volunteer, and this hotline is open 24/7, will stay on the line with a person who is using alone, and if they become responsive at any point during the call, they will activate the emergency medical services system. So prescribe naloxone or dispense naloxone kits. Again, naloxone is an opioid antagonist. It reverses opioid overdoses. It's effective against fentanyl and fentanyl analogs. You may have to use additional naloxone in a given situation. There are many things that are mixed into substances sold on the street, including xylazine, which we're not going to talk about in detail today. But xylazine is more similar to a medication like clonidine, so it is not responsive to naloxone. So if somebody is in an overdose situation and is not responding to naloxone, it's very important that you get that person to appropriate medical services, emergency medical services, as they may need different types of treatment and medication to reverse a non-opioid overdose. Naloxone's easy to administer. It has no effects if there are not opioids in the person's system that you're using it on. Um, there are no medication interactions between naloxone and other medications, and it's not contraindicated with any comorbid medical or psychiatric conditions. So it's really important that naloxone be in the hands of people who use drugs, who actually experience and witness and do the most reversals. And again, overdose education should be done with all patients, regardless of their diagnosis, their last date of use, or their intended substance of use. And I put how to write a naloxone prescription there. A reminder about fentanyl test strips. So anybody who's using illicit substances should check a small amount of their substance using fentanyl test strips. As I mentioned, there are some complications in using fentanyl test strips to test stimulants with. So high concentrations of illicit stimulants and cutting agents cause false positives on fentanyl test strips. So in this study, they looked at how often they got false positives on stimulants using fentanyl test strips. So false positive results indicating the presence of fentanyl were obtained from samples of methamphetamine, MDMA or ecstasy, and diphenhydramine, which is Benadryl, at concentrations at or above 1 milligram per milliliter. Diphenhydramine or Benadryl is a common cutting agent in heroin. The street sample preparation protocols for fentanyl test strip use, suggested by many online resources, would produce such concentrations of these materials. Street samples need to be diluted more significantly to avoid interference from potential cutting agents and stimulants. So here's a little bit more information on that. So when testing methamphetamine or MDMA or ecstasy for fentanyl, you must dilute the sample you are testing down to 2 milligrams per milliliter. This is about 1 teaspoon of water for every 10 grams of powder or crystals. If it's more concentrated, you may get a false positive result. So if it's more dilute, the strips may not be able to detect fentanyl or its analogs. A set of instructions has been going around on the internet telling methamphetamine users to add a few milligrams of meth to half a cup of water that is too dilute. So basically, they want you to do it at the measurement that I gave you. So again, you want to test it at 2 milligrams per milliliter. So where can I get fentanyl test strips? So right now, federal funds may be used to purchase fentanyl test strips. I just recommended that programs purchase and dispense fentanyl test strips to all persons using illicit substances. Fentanyl test strips cannot be prescribed. For programs who intend to dispense fentanyl test strips, the cost is about $1 per fentanyl test strip. Programs may purchase fentanyl test strips at several sites on the internet, including DanceSafe and BTNX. For people who use drugs who would like to access fentanyl test strips, you can refer them to a syringe service program. And for people who use drugs outside of New York City and who cannot access a syringe services program, they can order fentanyl test strips confidentially at www.nextdistro.org. In the near future, the OASAS Division of Harm Reduction will be supplying naloxone kits as well as fentanyl test strips to all OASAS programs. However, the mechanism isn't quite in place for that yet, but stay tuned for that in the near future. My conclusions. Psychostimulant use, particularly with methamphetamines, has been increasing. Trauma-informed care and person-centered care that are delivered in a non-stigmatizing and non-judgmental setting are a fundamental part of delivering substance use disorder care. Overdose deaths involving psychostimulants have risen markedly. Persons who use psychostimulants may not recognize their overdose risk. Psychostimulants, particularly methamphetamine, are associated with potentially more harmful behaviors, increasing risk for STI and HIV acquisition, and potentially long-term neuropsychiatric effects. There are medications showing some efficacy with psychostimulant use disorders that can be used off-label. Utilizing other modalities of treatment such as CBT, contingency management, and community reinforcement, etc., in conjunction with these off-label medications can increase efficacy. Harm reduction strategies and motivational interviewing employed in a low threshold, non-judgmental manner are important for engaging and retaining patients in care. Overdose prevention, including naloxone prescription and/or distribution, and education regarding fentanyl test strips should be done with all persons using any substances acquired illicitly. Here are some additional resources on methamphetamine that you can access online. And if you have any questions, you can reach me at my email, kelly.ramsey@oasas.newyork.gov. Back to Dean.
I want to thank Dr. Ramsey for today's program. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you've viewed the presentation in its entirety and completed the quiz, if prompted, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.